All right, welcome to Chapter 7 now of An American Sickness by Elizabeth Rosenthal, part of the Luigi Bookshelf series. Now, this series is kind of hit and miss on whether or not we should stick with this. First of all, I want to say every chapter is much like the previous chapter, just more sickness, sickness, sickness. No wonder the book's called An American Sickness. The healthcare system in the United States is sick. And it's like, how many more chapters do we need? How many more chapters do we need saying the same thing? Every step of this system, from the top to the bottom, every connected industry to the United States healthcare system is sick, 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 and demented in the head. And so as I read another chapter, I'm like, once again, like, how much more can you say? If you're not already convinced that that this is a problem, nothing's going to convince you. Not another chapter is going to convince you. So there, in that part, I feel like if I were a viewer, I'd be losing interest. Like, yeah, your system is broken. Do I need another chapter telling me that your system is broken? I figured out your system was broken before I even read the book, and certainly by chapter 1. But now you're 7 chapters in, and all you're doing is, here's another part of the system that's broken, and here's another part of the system that's broken. And also, I want to say that the series is not super well watched. So there's a part of me that's like, again, let's like we're reading things that are just like repetitively telling you how bad things are. We get how bad things are, and the audience that watches these videos is relatively small. And the last time I asked for some kind of feedback to say, hey, is anybody really still in this series? I asked for 2 people to tell me that they're still in, and only 1 did. So maybe that's a sign that this is not going well. But I'm going to go ahead and give you Chapter 7. I haven't decided to put a wrap on this book. I think it's important information. I really want to get to the ending chapters in Part 2, because Part 1 is basically defining the problem. I think Part 2, which looks like it's a smaller portion of the book, is, and what can you do about it? That's going to be the monumental part. So even if for some reason we decide to shut down this series because it's just not well received, maybe we'll skip ahead and I'll do some videos summarizing the and what can you do about it part. But for now, I'm kind of just telling you that I'm kind of having reservations because it just doesn't seem to be a well-watched, well-received series. The retention of viewers who watch it is lower than any other of the videos. And so there's a very small niche of people who are interested. But for you, small niche, I'm still doing it. And it really would help if you let me know that there's more than one person. And by the way, for the one person who said that you are in, thank you so much. You've been a long-time supporter. I'm sure there's things you don't like about what I do, the shouting in particular, but I do appreciate your constant and continual support of the channel. And even if you don't see eye to eye with everything I say, you have been a steadfast rock. So now it'd be nice if anybody else also would let me know if you are interested in this series or whether it's time to put a fork in it because only one person interested. Not to say that one person isn't important enough to continue the series, but again, it'd be nice to know that there's more people interested. So let's just get into it. Chapter 7. And I need to start a timer. I just realized one of the things that I've been trying to do, and I should have done this before I started, but I don't want to start the intro over again, is set a timer. So I'm going to set a 45-minute timer because I probably talked for at least 5 minutes right now, and see if we can wrap this up. Now, by the way, this chapter right now is primarily a big portion of one person's story. It's a woman, to summarize a little bit, but there's a lot of paragraphs I want to read, and so that's going to be hard to get through in 45 minutes. But to summarize, a woman who's basically low income, a struggling mother, I think a single mother, trying to take care of children and trying to provide for her family, and she has headaches, which turns out to be a bigger issue than she thought. It turned out to be a brain bleed, and it basically devastated her entire life, destroyed her family, destroyed her family's future, her kids' future, everything, because the medical industry and its predatory measures were, oops, you got a brain bleed, we really don't give a shit, go bankrupt, sell everything you own, cash out your insurance, cash out your life savings, your kids don't get to college, F you, we don't care, you need to pay up, bitch, is the message of this chapter. So I tried to put that as bluntly as I can. Let's get into Chapter 7. All right. So again, it starts out talking about the woman and her basic simple problem. Anybody could face this in America: a headache that turns out to be something bigger, a brain bleed of some kind, and then your life is over. This is one of the things that's a common thing in America. You are one sickness, one major illness away from being bankrupt. Again, I've said this many times: 2/3 of bankruptcies in America are healthcare related because of the costs of healthcare and our inability to pay for it, and that bankrupts 2/3 of the bankruptcies in America are based because of healthcare related issues. Soon after Mrs. Wickizer, I'm probably going to pronounce her name wrong the entire time. So soon after Mrs. Wickizer returned home to her loving family, she started receiving a torrent of bills. This was on her headaches that turned out to be something more and she didn't realize. $16,000 was billed to her from Centra Norfolk, not including the scan or the ER doctor. $40,000 more for the air ambulance because she got rushed by air ambulance. By the end of January, there was also one for $24,000 from some doctors at a bigger hospital. And she thought at this point, okay, that's not so bad, Ms. Wickizer recalled. And then it tells us that, but the next one came for $54,000, came a month later for the same physicians group, including $240 late charge, and then the hospital bill arrived for $356,884.42. She thought maybe I can make do when it was in the range of 60,000, no 75,000 for a poor person who doesn't have money, and then after 74,000, another 54,000 gets tacked on, and then she finds the real whopper, $356,884 on top of that. Living in a Navy town, Miss Wickizer had always been a law-abiding, bill-paying citizen, so she tallied her resources. She received about $2,000 a month in Social Security survivor benefits since her husband's death. He had worked for the city of Norfolk. So you put in your life's history, you work for the city, you get survivor benefit, now your spouse and your kids are living off of $2,000 a month Social Security. And she had about $100,000 of death benefits from her insurance payment. This is a story of many, many Americans. This is how many Americans live. So she has a 100,000 death benefit for insurance payment in a retirement account. That's probably more money in the bank than a lot of Americans have. There's a lot of Americans who are struggling and can't have $100,000 in the bank. But that's piddly. $100,000 for a family of 3 with children that need to go to college, that's not going to cut it. It's not going to cut it. But that's all she has. She's poor, really, by definitions, and maybe just a little above poor because she's got bank account with some money in it. But other than that, it's pretty poor. While raising kids, she had occasionally worked for a print shop and fraternal lodge that had never made more than $15,000 a year. With medical bills totaling near $500,000 now, the numbers didn't add up. My dad said they'll never expect you to pay that, she told me, but they did. Oh yeah, they did. In 2010, her extension plan ran out, and she tried to get, so she was on COBRA for a while. COBRA is another thing in America that's horrendous, right? So when you lose insurance because you're not working anymore and you're paying high premiums as it is for your company that you work for, you're paying high premiums and they match some of it, and that's the only way you can afford health insurance. But then if you leave or lose that job, you're allowed to go on COBRA. COBRA is basically it allows you to extend your health insurance coverage, so at least you have something at about 3 to 4 times the cost that it cost you already. So if you were as an employee paying $250 a month, which is on the low end nowadays, $250 a month for your health insurance, if you want to keep that health insurance after you lose your job or quit your job or whatever case and go on COBRA, it's going to cost you like $750 a month for the same coverage you were getting for $250. Most people can't afford to stay on COBRA, but she was on COBRA, trying to make it on COBRA. And in 2010, her extension plan ran out, and she tried to get insurance on the commercial market, but was denied by several companies, she said, because of pre-existing conditions. Oh, you're sick? You've got a history of sickness? Yeah, we're not covering you. We don't cover sick people. We only want to cover healthy people that aren't going to cost us any money. Fuck our system. Anyways, she had once taken medicine for mild depression, and because she had mild depression one time, she'd taken medication for mild depression, we're sorry, you have pre-existing conditions. You've got mental disorders. You've got problems. We don't deal with people with problems. We only insure healthy people who aren't likely to actually come asking for money. This would no longer be legal, by the way, according to this paragraph. This would no longer be legal, denying somebody because they had basically a pre-existing medicine for mild depression. That's not legal anymore since the enactment of the ACA. That left her in a state of a high-risk pool where she would pay $800 a month for a policy with a $5,000 deductible and 80/20 coverage thereafter. I don't know how much the world understands because I don't know what their systems look like about the whole 80/20 and deductibles, and so I will only briefly cover it. When you have a medical expense and it's $10,000, what it means is she would pay $5,000 of that $10,000, and then she would pay basically 20% of the remaining $10,000, and the health insurance would cover 80% of the remaining. So she'd pay $5,000 out of pocket right off the bat to meet her deductible for the year, and then there would be an 80/20 split with the insurance company picking up 80% and her picking up 20%. It's still more than most people can afford, especially when the hospitals and the system is allowed to charge whatever the fuck they want. And sorry for all the F-bombs. I get more and more aggressive as we get into this book. It creates a lot of anger and angst in me. She did her best to control her borderline high blood pressure through healthy eating and exercise because she couldn't afford medications. By the way, that's the same thing with me. I can't afford great health care, and so what I've had to do in part is one of the motivators was lose weight. I dropped 100 pounds on an exercise bike all the time, getting off my statins, getting off all the medications that I'm on, getting off the as much as I can because I can't afford to be sick. So I have to take care of myself to avoid the fact that if I get sick, I'm screwed. If I get sick, I'm bankrupt. In her own words, she was doing pretty well until a vessel in her head burst. Miss Wickizer acted logically. As a sign of good faith, she paid $1,500 to the hospital and $1,000 to the doctors and asked for the itemization of her bills. By the way, as an irony and aside in America, once you've paid anything on a bill, then you've acknowledged that you now owe that bill. So if you have any chance of fighting a bill in America, it used to be told to me, if you have any chance of fighting a bill, you can't pay a dime. You have to basically argue, I don't owe that bill and I'm not paying a dime. Once you've paid a dime on a bill, you've now acknowledged that you owe that money. And so her trying to do the right thing, paying $1,500 or $1,000 here and there, was acknowledging, hey, you acknowledge that you owe $358,000 or close to $500,000 in medical bills because you paid on it. So therefore, you're acknowledging the bill's good. A month later, on March 19th, the hospital finally sent a list of charges. Despite being 60 pages long, the tally was incomplete, and many charges made no sense. There was a room charge for one day of $4,762, presumably when she was in intensive care, for January 12th, and then another for $1,509 for another day on January 15th. No charges were indicated for the other 19 days she was in the hospital. A CAT scan on January 12th was billed at $1,579, but there was no record of her many other scans that she had. 2 stool softener tablets on January 12th were billed at $12.18, despite costing about $5 for a full bottle of 100 in a drugstore. $12 per pill, she could buy a whole bottle for $5. But you don't get to fight those things. You just fucking pay. I'll try to stop the F-bombs. I will try to stop the F-bombs. She also received the actual bill demanding payment of $356,884.42 for the hospital portion of her care, broken down only into broad categories: $111,162 in-room charges, $34,755.75 for pharmacy, $19,653 for labs, $8,640 for the operating room, $8,325 for anesthesia, another $1,143 for the recovery room, $44,524 $24 for the medical supply, $40,489 for the radiology services, and more. The bill informed her that the medical center was prepared to offer her its standard 20% discount for patients who are uninsured. Oh, I'm sorry, you owe $500,000? We can offer you a 20% discount on it, leaving what you owe now $285,507.54. It noted that the hospital could offer some additional financial assistance, but only if her household had assets of less than $3,000, such as bank or retirement accounts. Well, we know she has $100,000 in retirement account in her bank, so she doesn't qualify for financial assistance, which disqualified Miss Wickizer and likely most Americans who have ever had a job. So if you have ever had a job and you have more than $3,000 in your bank, you don't qualify for the financial assistance. Thank you for choosing this was the arrogancy of the... I told you I was going to stop the F-bombs. Thank you for choosing the hospital for your healthcare needs, the notice read. We hope to serve you again if your health need arises. Why? How can I afford your help? Your help can kiss... Okay. Anyways, no, I can't afford your help. So, hey, thanks for letting us help you. We want to be there for you. We hope that we can be there for you again with that $500,000 bill for your brain bleed. After scanning internet chat rooms on helicopter ambulance services, Mrs. Wickizer negotiated with the air ambulance company, which agreed to take $8,000 for their $40,000 bill. So on her own, she looked up what it cost. She's like, hey, look, this shouldn't cost $40,000. Okay, we'll take $8,000. If she hadn't argued, there wouldn't have been a negotiation. And the company operator made her promise not to tell anyone about the discount, as if she were getting the bargain of a century after it had taken nearly a 10% of her life's savings. So she wipes out nearly 10% of her life savings to pay for the air ambulance, and they're like, hey, don't tell anybody about this, because if they find out you screwed us out of $32,000 on the bill that really was an imaginary number in the first place, other people will try to do it too. So you're not to tell anybody that we cut down your $40,000 bill to $8,000, which probably only costs them actually like maybe $1,000. But anyways, we're not going to get into that. Medicare would, oh yes, we will get into it. Medicare would have paid, apparently, for that helicopter. Medicare would have paid $65,000 to $80,000 for the health thing. So in other words, insurance would have paid up to $80,000 for what they charged her $40,000 for without insurance. So again, you have insurance, the price goes up because you got insurance. So we can just bill whatever the hell we want. So $80,000 for the air flight if it was under insurance. Uninsured, $40,000. Then she finds out that's overcharged, and okay, maybe we'll take $8,000, but don't tell anybody, because we're really eating it in the shorts here, even though they would have charged her $80,000 if they had insurance. When the hospital billers called insisting on payment of the full $285,507.54, she patiently explained, I don't have that kind of money. She offered her $100,000 retirement account. So she's offering to cash out her life savings, leaving nothing for her and her children at all. And she's like, okay, I can't give you $285,000. I'll give you $100,000. I'll give you every fucking thing stopping the F word. Everything I own. I'll give you everything I own. I wipe out my kids' education. But the hospital declined and suggested that she sign up for a payment plan of $5,000 a month, which is untenable. She was only getting like, what, $2,000 a month in Social Security benefits? On the 3-hour drive home, she decided that she was willing to drain her retirement account, but would declare bankruptcy before giving up the house. So now she's trying to protect her house because they're taking everything from her. They're taking all of her life savings, everything from her children. Her future is gone, wiped, destroyed. Understand, her future is destroyed. She's now willing to, okay, my kids don't go to college. I get nothing. We're wiped out. We're broke. But I want to save the house. So I'll declare bankruptcy and maybe I'll get to keep my house. Maybe I'll get to keep my house. Or maybe you'll kick me and my kids out on the street. They don't give a shit about you. Studies have shown that hospitals charge patients who are uninsured or self-pay 2.5 times more than they charge those covered by health insurance, who are billed at negotiated rates. So here, in this case, the hospitals will charge people more if you're uninsured than they do for people who are insured, because the insurance has a negotiated rate. So sometimes they get to bill whatever the hell they want. Other times they bill even more because they can get away with billing more than the negotiated rate. It's just a game. And 3 times more than the amount allowed by Medicare. The gap has grown considerably since the 1980s. Now here's a new paragraph. Blue means it's a slightly different thought that I have, and I'm going to read it and figure out what my thought was. After Ms. Wickizer posted about her plight on the internet, a dream team of billing specialists, patient advocates, and healthcare lawyers from other states offered to help her pro bono, but encountered roadblocks at every turn. Multiple requests to review Wickizer's complete bill were refused by the hospital. So great. She's got some people who are like, you're getting screwed. It's not right that a single mother of 3 is getting kicked out of her home, destroyed her life savings, everything's gone. We're going to help you free. But the hospital's fighting all of the experts who are like, hey, let's get a freaking itemized bill so we can talk about the money. No, you can't get that. The billing snippets the hospital had previously sent along to Miss Wickizer were error-laden, said Nora Johnson, a billing specialist in West Virginia who was involved in helping her. There was a charge of $82,640 for ambulatory surgery, a clear mistake. Mrs. Wickizer had arrived in a coma for an emergency intervention. So where did the ambulatory surgery come from? Of $82,640. So they know there's errors. That didn't even make sense to what actually happened. Even by its own calculations, the medical center spent only about $77,000 treating Miss Wickizer. So again, they charged her nearly $500,000. They only spent $77,000 treating her. Miss Wickizer offers to pay the university more than that by cashing out her retirement fund of $100,000 and is rebuffed. often in an insulting way, using blistering language. Your client may feel that she will never be able to pay the bill, and she may not feel truly well after going through the experience of a cerebral hemorrhage, wrote Peter Hetzel, a partner, insinuating that Mrs. Wickizer was not mentally fit to appreciate the grim reality of her predicament. So they're like, hey, sorry you're broke, but how would you have appreciated having that cerebral hemorrhage? That would have killed you. So be thankful you're alive, and now give us everything you own. Cash out your shit. So you're sorry we destroyed your life? You know, you have a life because we saved you. So now we get to take your life financially. I'm giving you the universal translator. He noted that judges in the area were known to side. He noted, the guy giving her this thread about, hey, I realize you don't think you can pay, but you can, and how would you like to have died? And by the way, judges typically side with the hospitals. So you're not going to win. They're going to side with us. In April 2016, more than 2 years after her surgery, Ms. Wickizer was nervously awaiting her face-off with the University of Virginia and its lawyers in court. So she's trying to sue. It's her last option. So that's kind of the end of that story, by the way. That's kind of the end of that story. Now we're going to get into the medical coding issue. We got 27 minutes left. I don't know if I can do this. Let me shut the hell up and get in it. Medical coding and coders like ours essentially don't exist in any other healthcare system. In the United States, we have a whole industry of medical coders that don't exist essentially in any other country. And unlike an Uber driver or a solar panel installer, a medical coder really doesn't exist as a profession here 25 years ago either. It's new to America and it's new to the world. It's only here, and it's only because of the way that the healthcare system has gotten out of control. A detailed itemized bill for a hip replacement in Belgium takes about 3 pages, and it's not hard to understand. An itemized bill for the same operation in many hospitals in the United States would likely total over $100,000 and run in dozens of pages and filled with medical terminology and numerical codes that you couldn't possibly comprehend. Okay, so that's our system. The financial stakes in coding are high. If you code for a heart failure, which is ICD-9-CM, ICD is an international code diagnostics. I don't think that's exactly the terminology, but it's basically an international coding system for medical conditions that the entire world uses, including us, but we have put it on steroids. So the financial stakes in coding are high. If you code for a heart failure, ICD-9-CM, code 428, when you could code for acute systolic heart failure, code 42821, the difference is thousands of dollars. So according to a coding professional, in order to code for a more lucrative code, you have to know how it's defined and make sure that the care described in the chart meets the criterion for the definition for the higher number. So what you do is when you have somebody with a medical condition, you're like, oh, if I change the wording slightly to this, I can code at a higher code and get paid more money. And so things just get worded differently and so now they have specialists. We have coding specialists in the United States who specialize in finding a way to word it just right to get the most amount of money out of the code that you can possibly get. Submitting a bill using the higher code without meeting those criteria could constitute fraud. So in other words, we have to be careful because it looks like fraud if you're trying to word things just so you can get a higher code. Yeah, it does look that way. Anyway, so the coders who work for hospitals strive to get money. The coders employed by insurers try to deny claims as overreaching, and coders who audit Medicare charts look for the abuses that need to be punished. And this has created an entire lucrative business of people who specialize and go to college just to become medical coders. Suddenly, coding meant big bucks and a new industry thrived. For-profit colleges began offering medical coding degrees, and required internships soon followed. At these professional schools, students spend 6 months learning about anatomy, physiology, and pharmacology before the language training begins. Coding concepts are taught by major disease category. Highly skilled coders have contributed to higher costs for patients because the salaries of the new layer of professionals and their years of education are reflected in the medical bills. So, okay, we're going to help the patient by helping them figure out the coding issue. But you know what? It costs a lot of money to be trained in as a professional coder, and so we're going to add that onto your medical bill. Oh, sorry, you got more expensive bills now instead of less expensive. Sorry about that. That's unfortunate. But you're going to have to pay because it costs money for me to go to school and become a coder to help you. Do you not see how bad this is? You do. You do. We all see it. In 1996, Medicare's National Correct Coding Initiative made it clear that certain CPT codes couldn't appear on the same bill because they were inherently part of the same procedure. In other words, you can't double bill the same procedure, but it was happening. While ICD codes indicate diagnosis, CPT codes indicate medical services. As a rule, an anesthesiologist could not, for example, separately bill for anesthesia and checking your oxygen level during the surgery. One subsumed the other. In other words, if you're putting somebody on anesthesia, checking their oxygen levels is kind of par for the course. So you can't bill once for putting them under anesthesia and then another time for checking their oxygen levels, because that's part of putting them under anesthesia. But they would do that anyways. But the government created a modifier. Here we go. Every time the government tries to put in something to make it better, it gets abused. So here we go again. Can I do this in 20 minutes? I don't know. So it says, but the government created a modifier 59, a code that could be appended to other codes to allow doctors to take exceptions to the rule in rare cases. So in other words, you can't double bill, but we're going to allow this thing called modifier 59 that allows it under certain conditions to double bill. So modifier 59 could be deployed to allow for two payments in certain situations, such as when an oncology nurse needed to insert two separate IVs, one to administer chemotherapy and another because the patient appeared to be dehydrated. Okay, so there's some conditions in which you can double bill for inserting an IV because maybe there was two different purposes for those IVs. Okay. An investigation by AS008 in 2005 found massive evidence of modifier 59 abuse. Oh, so they created a new modifier 59 thing and people learned how to abuse it. What a shock. In the medical industry, please. 40% of code pairs billed with modifier 59 in 2003 weren't kosher, resulting in $59 million in overpayments. So modifier 59 allowed people to double bill again, so maybe it was designed to help clarify things, and all it became is a place to bilk another $59 million in overpayments. Instead of resolving the problem, such attempts at clarification simply created a secondary business of even more advanced coding consultants who advised other coders as well as healthcare providers and taught courses that covered the nitty-gritty of insurance reimbursement policies. For example, an ER doctor learned that insurers would accept a better reimbursement code for the examination and treatment of a patient with a finger fracture, usually code 99282, if a narcotic painkiller was prescribed, bumping it up to 99283. So anyways, you got a broken finger, let's add a painkiller, now we can get a better code, we can get more money. With that type of guidance, some surgeons stopped suturing wounds shut after their operation and instead handed off to another doctor, say a plastic surgeon, who could therefore code and charge separately. Oh, so let me get this straight. So because you can make more money, you're not going to suture up a wound shut after an operation like you would normally have done, and you're going to pass them on to somebody else who can charge them more money because, cha-ching, we're all about making money, bitch. This isn't charity. We're not doing this for your health. Literally, you are health insurance, right? Or anyways, health industry. All right, 21 minutes. In April 2015, the Business of Spine, a coding consultancy that serves spinal surgeons, issued an urgent coding alert. Coding alert! Coding alert to people who are in the coding business. Medicare had just issued a new set of modifying codes to modify modifier 59 for 2015 that it expected doctors to use. So now we have a modifier on modifier 59, and the insurance agency is like, warning, warning, check out the new modifier to the modifier 59. Modifier XP, for example, meant a part of the procedure that was distinct and could be separately billed because it was performed by a different practitioner. So, there's the loophole. If we can pass you off to a different practitioner, you can double bill for the same procedures. Cha-ching! Another way to make money. Okay. So companies like 3M began selling encoder programs to help coders track the latest shifts and optimize payment. Coders often work off-site, even from home, with no knowledge of what actually occurred in the surgical suite or at the patient's bedside. They make many assumptions. So now we've got a whole industry, the working from home, that aren't even part of the system, trying to figure out how can we double bill and pass this off other things to make more money so that we can get more profits. Cha-ching! All right, the latest iteration of international disease codes, IDC-10. So now IDC-9 was the old standard, then IDC-10 was the new standard, okay? So the latest iteration of international disease codes, IDC-10, this is used around the world, was completed in 1992 and has been used by the rest of the world for decades. Why did it take the United States until 2015, so many years later, that's what, a decade and a half or whatever, to fully deploy it? The problem was that the United States medical billing system and how to game it evolved based on ICD-9. So we know how to game the system in ICD-9. The world has moved on to ICD-10. It's going to take us a lot of time to figure out how to bilk the new system. So the United States was just lagging behind. Let's just not move to ICD-10 because we know how to game the system on ICD-9. Criminals. These people should be criminals. That was not what you think I was about to say. I know what you think I was about to say. But this is criminal behavior in many people's books. Changing to the new system, which identifies medical conditions or more specifically using new numerical codes, was good for international epidemiology, but terrible for business in American medicine. So what was working around the world, it wasn't working for American business, so they lagged behind and stayed on the ICD-9. When I visited his office in 2014, Dr. Hayes needed to get pre-certification, also called prior authorization, for a nuclear medicine stress test, CPT code 78452, for a patient covered by a Blue Cross Blue Shield plan. His patient, a man with heart disease, diabetes, high cholesterol, and new chest pain, clearly needed the test. But Dr. Hayes' office manager was not proving that to the insurer itself, and instead to a proxy company called CareCore National. So in other words, he has to use a third-party manager to prove that this person needs a test that is clearly in need. Like most insurers, the plan had farmed out its pre-certification and contract to a middleman who might work for free, but is compensated by keeping a portion of the money saved by making getting a test really difficult or denying care outright. So in other words, this CareCore National provides a free service of helping out with the pre-certification process in exchange for a cut of the money that they save if they deny it. So really, they make it really difficult for or denying care outright. That's how such firms make business case for their services. The original intent of pre-certification when it arrived in 1990s was to review a small number of really expensive procedures and determine whether they were truly needed. Because pre-certification has become such a vibrant business in and of itself over the years and remains a great way for insurers to save money, the requirement for pre-certification has trickled down to the most trivial of medical needs. When Dr. Barry Lindbergh, another New York cardiologist, received a letter requesting prior authorization for a patient's refill of an old generic heart medication, he faxed back, "Are you kidding me?" The doctors are getting pissed. Like, I need pre-certification to get somebody a medication that they've been on, an old generic heart medication, and now I have to have pre-certification, pre-authorization to give them a medication that's been around for forever and has been approved and you already know is medically safe and all those things, but I still need pre-certification? Are you kidding me? Who's on the patient side? Now this one is going to be interesting to me because it has Change Health. Have you heard Change Health? If you know the United Healthcare situation well, you know what Change Health is, and I will try to do my best to try to explain this. These are patient advocates. Patient advocates. So this is a company that's supposed to work on behalf of the patient, like Change Healthcare. Employers hire services like Compass or its large competitors, Castlight Health and Change Health. You've heard of Change Health because such companies promise that the investment of, say, $50 charged per head of their employees can save them money on the average patient without harming quality. So in other words, companies will pay Change Health to help negotiate between their employees who are on insurance and the insurance companies to save money for the company in insurance bills and all this stuff like that the employers are paying because they're paying your insurance premiums and all these things. So this independent or this group in between called Change Health, and I'm just going to focus on Change Health because this is at the heart of the United Healthcare situation. I'm going to hope that I get this right and explain what happened. So this is a patient advocacy group, Change Health, that is helping negotiate your rates with the insurance companies. Compass says that it has saved its clients $375 million of late. Now, what did United Healthcare get in trouble with before the Brian Thompson situation? One of the things they got in trouble with is that United Healthcare wanted to buy Change Health. And the Department of Justice, this is my understanding, so I may be wrong. The Department of Justice, basically, they were told, United Healthcare, that seems like a real conflict of interest. So you're an insurance company, and Change Health is an independent company who's negotiating rates with the insurance companies on behalf of the patient, and now you want to buy the middleman between the patient and the health insurance company so that you also own the middleman between you guys. Are you following this? So Change Health is a patient advocacy to help the patient get a better rate from the insurance, and now insurance wants to buy Change Health. So when you're dealing with the company that's helping you negotiate with the insurance company, they are owned by the insurance company. Rightly so, the government said, you know, that kind of sounds like an antitrust monopoly kind of situation. You're literally owning every piece of this business from top to bottom, including the patient advocacy group. And so, rightly so, United Healthcare was told not to do so. United Healthcare went forward with their plan and bought Change Health, to which the Department of Justice initiated an investigation into antitrust laws because they had done something dastardly. You are literally buying every part of this thing. There is no help for the patient when you own the patient advocacy group as well. So they were under investigation. And during that investigation, before it was announced to the public that United Healthcare was under investigation for antitrust laws for buying Change Health when they were told not to, all of a sudden, Brian Thompson and Andrew Witty, the CEO of Andrew Witty is his boss from United Health Group. So Brian Thompson, United Healthcare, and then above that is United Health Group. So Brian Thompson, Andrew Witty, both sell a shit ton of United Healthcare stock, and basically decimate a Hollywood fireman's pension plan, decimates their plan by knocking the shit out of the stock price of their pension plan because they dumped a whole bunch. I think Brian Thompson sold $15 million worth of shares. I think maybe Witty did even more. I'm not sure. But anyways, they dumped a bunch of stock before it was announced to the public that they were under investigation by the Department of Justice for antitrust laws. So the fire department, who lost their ass on the pension plan, got pissed and filed a class action lawsuit for insider trading against United Healthcare. Are you following all this? I wish more people would see this video and understand the process. This is the way I understand it. If I'm wrong, please educate me. But that's what I believe has happened. United Healthcare decided to buy one of these patient advocacy groups. The government said that seems like that's a real conflict of interest for you to own the broker between the patient and the insurance, and you are the insurance company. How can you own the middleman? It said no. They did it anyways. They were under investigation. They dumped a bunch of their stock before it came out that they were under investigation so that they would get the price. They'd cash out at a real high price, and then everybody else just gets, when it gets announced that they're under investigation and the stock price dives, they're out. They didn't lose a shit ton of money. Everyone else loses a shit ton of money. All right. Patients, however, are not the only or even primary customers of such trusted guides. Many companies that advocate for patients also make good business by providing price information to hospitals, doctors, and insurers who want to know how much their competitors are receiving for medical encounters after negotiation. Companies that promote healthcare price transparency generally start by collecting claims, either purchasing huge claim databases from other companies that own them or crowdsourcing prices in some way. Each employer that hires a company for patient advocacy, like Change Health, or transparency, provides a cache of insurance claims which help determine what prices are achievable in an area. What is the universal translator way of saying this? So we're trying to pay a advocacy group on behalf of patients, but in doing so, we're giving them all kinds of information about what the insurance companies have been getting away with, and the more that the insurance companies know what they've been getting away with, the more they can set higher prices because they know what they can get away with. I did it in 50 minutes. I'm going to have to tag up this episode with Change Health and United Healthcare for people who are watching this, and Luigi Mangione, so that the people who are not in this book series have a chance to understand a little bit more about what was happening in my understanding of the Department of Justice investigation into antitrust when United Healthcare bought Change Health, and the stock dump when they were under investigation for insider trading. Witty apparently is still going to face that investigation on both sides, both the antitrust and the dumping of stock, the insider trading. But Brian Thompson cannot. Because he's not with us any longer. And the question becomes, did somebody retaliate against Brian Thompson from the health insurance, or from the pension plan, the fireman's plan that was decimated? Did somebody who lost their life savings in that plan shoot Brian Thompson because of what he did, selling off his stock? There's a million people who have motivation There's millions. One can argue there's 300 million Americans who have motivation in some way to be upset with what happened with United Healthcare. Okay, not all 300 million Americans are United Healthcare customers, but they are the largest. And so, point taken. So again, I want to clarify, reiterate, this is not a call to action. It is not a call for violence. I'm not asking people to do anything horrendous to do this. We're educating ourselves in a horrendous system. This system is about, or this whole book series is about education. And understand that Luigi Mangione is facing trial for shooting the CEO of United Healthcare, who was under investigation by the Department of Justice for their practices of buying out Change Health, for insider trading, for dumping stock, and this would make a lot of people angry. Luigi Mangione would not be the only person who might take issue with that kind of practice. Hopefully you also take issue with that kind of practice. That doesn't mean I say hopefully you also do what allegedly Luigi did, but let's remind you, this is allegedly. Luigi Mangione has not been proven guilty in a court of law, and he is presumed innocent until proven guilty. The other question that you have to ask yourself from the philosophical standpoint is, if these companies are doing these things, how many people are dying every day because of denials of claims, being bankrupted by their insurance companies, having nothing left for their family and their future, and forced to live on the street? How many people are dying indirectly for this stuff? To act like nobody on the healthcare system has any culpability in deaths, and only one man who shot somebody on the street is the only person who's the cold-blooded murderer, is not seeing the big picture. The big picture here is this is a predatory healthcare system, in my opinion. It is a predatory system that is literally taking lives away and not letting people have their full lives because people can't afford this predatory system. So again, not a call to action. It's an educational video. It's for educational purposes. Thank you for listening to this chapter. It's become much more emotional and powerful than I expected it to be. This was a difficult chapter to read and digest. Again, if you want to see more of this content and you're still enjoying this book, please let me know in a comment, and like, subscribe, hit the notification bell, follow the links at the end of this video to get to the start of the series or to continue on. Whatever you can do to support it, let me know, because I feel like this is important information. So thank you and have a good day.